And today we are going to start with discussing this topic, which is Caries management system. It's Ivan's article for the application for the adult. So we will be talking about adult teeth. Okay, there is some different strategies that we need to do with the kids. So this topic is this article is mainly based on the adults, but there is a little bit of difference in the kids. Okay. But even after reading this article, if you will go to the kids one, you will be more better. You will be like in a better place to understand that. Okay, there is no need to read this introduction and need for new interaction. You can definitely read this thing, which is diagnosis and interventions, and the main focus is here, which is the caries management system. So there are 10 steps that we need to follow to arrest and or remineralize the early lesions. Okay, so which 10 steps we have is the diet assessment, plaque assessment, bite wing x-rays, so diagnosis and caries risk assessment, preparation of treatment plan, and how we need to present the case, and what will be the management strategies such as like oral hygiene coaching, fluoride application, and monitoring of plaque control, and also the recall visits. So in this topic, we will understand how in total we need to do a holistic approach for our patient, just to from the start to the end, so that we can continue monitor their progress. So there are some governing principles for the caries management, which include we first need to find out whether is our patient at risk. If he is either he is at high risk, low risk, or medium risk, then we need to find out what is the status of each lesion, and then we need to tailor our management strategies accordingly. Okay, and we need to do the clinical management and also the monitoring, which is very important. Okay, so now the patient at risk of caries. How we will find out whether our patient is at risk or no? By taking history and doing the clinical examination. Okay, so dietary assessment, we need to give them the diet diary that they will fill in. That we need to ask them that you just need to write down whatever you are eating and what time you are eating for 2 weekdays and 2 weekends, so that we can assess in the next appointment and work on it, just to find out what is like going on, because generally any type of decay linked with either the dietary factor or the oral hygiene factor, and sometimes some systemic factors, such as like if some have some medical condition or taking some medication, so that can affect the saliva constitution, and it can lead to more higher risk of having a decay. Okay, so in this appointment, we will be just giving the diet diary. We do not need to educate the patient at this point of time, because otherwise he will just write down everything, which will be like, good thing. Okay, and then assessment. Second step is that we need to assess the dental plaque control, how well we need to how well the patient has the plaque control by doing the regular brushing. So how we can check how much plaque level he has is by using the air and the explorer. So if there is no visible plaque and cannot be wiped off with an explorer, then the patient has zero level. But if we can wipe out with the explorer, then it is at level 1. If the plaque is visible along gingival margin with or without air drying, then it's level 2. But if there is a thick and visible plaque present along gingival margin, then it's level 3. So you need to make your patient according to that level. Then the third step will be the saliva assessment. So generally the saliva assessment is in this we just understand what is the quantity of the saliva, because we need the saliva for flushing away the bacteria and food particles, and also the buffering capacity of the saliva, right? So generally this saliva test is done in the hospital, in which they will give the patient chewing paraffin wax. They need to chew it for 2 minutes, so they will and then they will collect the quantity, and measure it. If this saliva quantity is less than 1 milliliter, then the caries risk is assessed as higher risk. Okay, so we just need to do these steps just to find out how much risk does our patient have of having any decays. And then you need to find out status of each lesion. For example, whenever the patient comes, we first take the history, we do just the thorough checkup, and then we do the dental charting. So with the dental charting, you just need to do clinical examination. You need to find out by doing air drying and using the blunt probe. You just need to probe each lesion and look with sharp eyes and air dry it, because with the air dry, the yeah, it can show different changes. Okay, these are recorded on standard dental charts, and unless frank cavitation is evident, the diagnosis of dentine caries is via a radiographic bite wing survey. Okay, so if you can see a frank cavitation, then you need to measure it how deep the caries is by taking an bite wing X-rays. So these are generally done every 2 years for low risk patient, but if the patient has high risk, it can vary. Okay, so for the criteria for scoring between radiolucencies will be C0 will be no radiolucency evident. C1 will be on the X-ray whenever you are reading the X-ray. If there is no radiolucency, it will be categorized as C0. If there is a radiolucency but it is within the outer half of enamel, it will be C1. If it is in the inner half of enamel and may reach DAJ, then it will be C2. But if it just extends the DAJ, which is the dentino-enamel junction, then it will be C3. If it is in outer third of dentine, C4, inner two-thirds of the dentine, C5. And how will you assign the caries risk according to all these findings you have? So, if the patient, in the new patient, if they do not have any clinical signs of caries, but on the x rays you can see some radiolucencies which are not greater than C3. So, they are at low risk. And for the recall patients, if they have one less new lesion, it means zero new lesion per year or no progression of existing radiolucencies, they are under low risk. But if the patient has no frank cavitation, but they do have some sticky pits or fissure, and the bite wing radiolucencies not greater than C4. Okay, so it will be considered as medium risk. One new lesion per year or progression of existing radiolucency will also be medium risk. So with the high risk, if they have untreated frank cavities, extensive white spot lesion, or C5 bite wing lesions. Okay, and for the recall patient, if they have more than one new lesion per year, then they will be considered as high risk. Okay, then assessment of patient's caries risk status. So we will assess the caries risk according to this chart. So you need to find out whether they do have any caries, any signs of caries clinically and radiographically, and you just need to categorize them accordingly. So now we have taken the history, we have done the examination, we have categorized our patient. Now we need to do their management. So how will we do the management? It will be done according to how much caries risk they have, right? And what is the level of decay. So in the case management, as we know the 10 steps that we had, so we need to give them the dietary advice, which is we need to educate them about the frequency of taking sugar and the acid contents of in the drinks, acidic and sugary, and also about the hidden sugars, which most of the patients are not aware about them. So you just need to give, it's because we are not only treating the holes, we are making the patient aware about all these things as well, so that we can prevent it in the future. So you need to give the dietary advice. You need to give them the demonstrations how to brush their teeth and do the flossing. Okay, and also with the clinical management, we need to do it according to their risk. So preventive, preventative, and operative. So cavitated lesions are managed using operative procedures. Sealant should be placed without the removal of any tooth structure over pre-cavitated incipient or friable. If they have deep fissures or friable fissure, just put some sealants because it can prevent the cavities to happen. They will need to be checked regularly as stained caries arrest depends on sealant retention. Most other lesions discovered as a result of the Bitewing survey are managed with non-invasive methods. So we will need to go to table 5. So in the C1, C2, and C3. So until this level where the caries are just extending just beyond the DJ, you do not to put a filling there. You can just do some topical fluoride and monitor them and educate the patient. But if the caries is extending into the dentine, then you need to do the further consideration. So the further considerations will depend upon whether the patient is low or medium risk or high risk. So in the high risk patient, you do not need to think twice. You just need to restore the filling. Okay, and also apply the topical fluoride and monitor to arrest other lesions so that we can remineralize them or prevent the recurrent caries. But for the low and medium risk, restore only if the radiolucency extends fully one third into the dentine. Otherwise, do not restore. Okay, because we can give them some chance that it can remineralize, but for the high risk patient, do not like double thing. You just need to restore the filling. Okay, and for C5, anyways, no matter what level patient has, you just need to restore it because it is in the inner third of the dentine. All right, then what tropical fluoride protocols we can use for adults age 18 and over? We can do either fluoride varnish, which is Durafed, or GIC Fuji 7, or the fluoride gel. Okay, so for the low risk patient, apply varnish or GIC to newly erupted wisdom teeth. Uh, 2 yearly for second is yearly application on lesions until arrested. So for the low risk patient, we can just put this topical fluoride, and fluoride gel is recommended at recall appointments to maintain the lesion arrested. For medium risk patient, apply varnish to newly erupted wisdom teeth and apply varnish to all the lesion at each appointment. Okay, here the application was just yearly at each appointment, then 6 monthly varnished application on lesion until the patient becomes low risk. And for the high risk, you just need to apply the varnish to newly erupted wisdom teeth, apply varnish to all lesions at each appointment session, and 3 monthly varnish application on lesions until patient becomes medium risk. So 3 monthly for high risk, 6 monthly for medium risk, and yearly for low risk. Home care, what you need to prescribe them, you just I would recommend do not get confused from here. In this table is present in TG as well, so you just refer that there, that what what toothpaste you can prescribe to the patient according to their risk and according to their age. And it is very important question according to exam pattern as well. Okay, then the next step is that you need to monitor the progress, like how they are doing. So the monitoring will be for the low risk patient every 1 yearly. You need to following completion of treatment plan developed at first visit. Okay, and then consider 18 to 24 months recall. Okay, and Bitewing survey will be at first visit, then 12 months later, then every 18 to 24 months later. Okay, and for the medium risk, you need to call them every 6 monthly until the patient is classified as low risk. And for the high risk patient, it is 3 monthly appointments. Okay, and for the Bitewing, for the high risk, we generally take 6 monthly Bitewing, and for the medium risk as well. But I think and for the low risk patient, we can take the bite wings every 2 years. Okay, and then the it's just the discussion, so you can read the discussion if you want to. It's just the like little bit more insight is given, but along with this article I would highly recommend reading the Caries topic from the TG, so that both of them will resonate better, and you will get better understanding of them. Okay, thank you so much for watching, and we'll see you in next video.